Guys, in this video I'm going to give you a brief overview of what hypertension in pregnancy is and the treatment in the pre-hospital setting and also in the hospital setting. I hope this helps. Alright guys, so hypertension in pregnancy has 5 different subclasses. Subclass number 1 is basically chronic hypertension, which is defined as hypertension that's 140/90 before 20 weeks of gestation. And subclass number 2 is gestational hypertension, which is basically the same as chronic hypertension, but it's after 20 weeks of gestation. And the treatment for these are basically labetalol, nifedipine, and methyl-dopa. And the reason why you don't give ACE inhibitors or ARBs is because these are teratogenic. So the third subclass is preeclampsia. Preeclampsia is defined as hypertension, proteinuria, edema, could have visual disturbances, abdominal pain, changes in liver function tests, and oliguria. So the mag sulfate is basically the treatment that's preferred for many different reasons. The mechanism of action of mag sulfate is not clearly understood of why it helps. The magnesium sulfate is given as seizure prophylaxis. Subtype number 4 is eclampsia. Eclampsia is basically pre-eclampsia along with tonic-clonic seizures, and the treatment for that is, once again, magnesium sulfate. Basically the way you set it up is you give 2 grams. You have 1 gram in here, so you give both of these. You can put it in 50 or 100 cc's with a 60 drop set, and you give it over 10 to 20 minutes. And remember, you must call medical control prior to administering this. Now, this is the treatment for preeclampsia, and if you have a person who proceeds into eclampsia, the magnesium sulfate can still be given. But one thing you want to add to that is considering your narcotics. All right. So basically, the way, like, for example, I had a patient that we went to her house, and we found the patient 30-something weeks of gestation, oral trauma, incontinent. The husband called because she had a seizure. When we found her, she had pedal edema. She just had the telltale textbook style presentation of a person who was having preeclampsia. We gave her the mag sulfate. The mag sulfate helped. She was post-stictal when we found her. She eventually became ANO times 3. Oh, that's one thing I gotta tell you. When you give oxygen to a person that is post-stictal, for the oxygen basically accelerates the person becoming alert and oriented times 3. So what we did with that person or that patient was we put her on oxygen. She became ANO times 3. We gave her the mag sulfate, and then she had a seizure witnessed by us. And I gotta tell you, this is one of the type of calls that stay with you forever, because it's not easy seeing anybody having a seizure, let alone a pregnant female who becomes cyanotic. They're bleeding because they bit their tongue. And basically what we did was we called telemetry. We let them know that the magnesium sulfate was administered but did not stop any seizures, and she is currently seizing, so we were instructed to give narcotics. It's not in the protocol, but we basically call for discretionary orders, being that the mag sulfate didn't work. With that patient, we basically expedited the transport. We notified the hospital that we were en route. We went to the nearest OBGYN receiving hospital, and when we got there, they immediately took her in, and if I'm not mistaken, they ended up doing an emergency C-section, and they administered hydralazine to control her blood pressure. So the 5th subtype is the HELP syndrome, which is basically hemolysis, elevated liver enzymes, and low platelets. These patients will barely be seen by paramedics unless you're like a critical care paramedic and you're doing an interfacility transport, because these patients are in very, very critical condition, and we probably won't be finding them in a pre-hospital care setting. Treatment of severe cases is delivery. Most likely it'll be via emergency C-section, and that's actually the reason why I used the picture that you see in the thumbnail, because it reminds me of a case that I worked with along with a couple of OBGYN residents, where this patient had, her blood pressure was like 230 over 160 over 150, and we had to rush her into the operating room and basically deliver the baby. The way we did it, or the way I helped them do it, was basically we gave steroids to allow for lung maturity. We prepped her and got her into the OR and delivered the baby. In the picture, you'll see that I'm basically helping suture up after the C-section was finished. Don't forget to bring your OB kit, pediatric kit, and high-risk kit if necessary. Bring your oxygen. Put the person on a monitor, preferably for vitals, not necessarily because you're thinking of a heart attack or anything like that. Start an IV, and then you could proceed on to giving the Mag Sulfate if they fit the criteria. And you could go all the way up to giving narcotics if the person goes into eclampsia. Okay, so basically that's what we do, and that's how we do it. I hope this helps. Please share this video with whoever you think could benefit from it. And remember, I'm at your service. If you have any comments or any suggestion, please leave it down below. Alright? Peace.